Thank you. It's a real honor to be here today. Like Jen said, we've talked about this 2 years ago, but to actually be here and present this for Pain DC, I'm a huge fan, as Jen knows, of all the work that Pain DC does on behalf of people in pain and supporting them and also educating healthcare professionals. So I'm Linda Crawford, and my biography was on the description of this webinar, but I just will tell you I've been in private practice for 6 years, specializing in working with people with complex pain conditions. So this is my private practice Brave Therapy. The CDWF after my name means I'm a certified Daring Way facilitator. That means I'm certified in Brene Brown's work. I'm one of the very few OTs in the world certified in her work, and I integrate that into my practice as well. I also, in addition to being an OT for over 30 years, I have a lived experience of persistent pain, 4.5 years. I'm happy to say that I am chronic pain, persistent pain free for the last 6 years. And I will say that I'm sharing today as an occupational therapist, but also from my personal experience, because being an OT really has helped me change my pain experience and change my life. So one of the things I do want to tell you is that the title that you saw advertised was Think, Feel, Do, but I want to tell you that I kind of tricked you, and that's not the real title. And here we are. Here's the real title of my presentation. It's Do, Feel, Think, Humanizing the Pain Experience from an Occupational Therapy Perspective. And I we'll talk a bit more about why I changed it and why I tricked you a little bit, but this is the occupational therapy perspective, that we are doing beings who feel and think primarily, and that doing is an occupation. So occupational therapy is based on the real life engagement and activities that people do. We consider occupation anything that we do. Back when OT started, occupation didn't mean having a job. It meant the things that you're engaged in daily life. So I think we can all agree that the way we pace the activities of daily life, we always talk about that with pain self-management. That's really important. But what I want to propose in this short presentation is to humanize the pain experience by digging a little deeper into how we experience the things we do, so that we can understand how critical it is to think about how we can change our experiences so we can change our lives for the better. So here's the traditional cognitive model of pain: think, feel, act. If you're a healthcare professional or a person in pain, think about the perspective that you use when you're working with someone in pain, or even when you're trying to self-manage your own pain experience. Do we come at it with this belief in this model system of that we think, and then we feel, and then we act? Because the premise here is that if we change our thinking, then we change our feeling, and then we change the actions that way. But I'm coming with you to you today with a different approach. I want to challenge your thinking a little bit. Let's start from an act or a do place to a feel, to a think. Since we're doing beings first and foremost, we're always engaged in activities. We also have feelings about that, and I don't mean just emotions. I mean we feel things in our body as well. And then they affect our thoughts. What if we took this perspective and began looking at the pain experience this way? Now, I will tell you, this isn't an official model of pain. This is just the proposed model for us to use today, and it's kind of an overview of the model of occupational therapy and the way we approach working with humans in pain. So this perspective is going to relate to everything: how we educate, how we support, and how we engage with people in pain that we're trying to help. And I want you to know, I'm not suggesting that we throw out the other approach, the think, feel, act. We'll talk about that more towards the end, but let's start here and let's see where it takes us if we refocus on the actual doing in our lives. So to review first, though, I want to give you some more background on on persistent pain, and this comes from the International Association for the Study of Pain, just came out with new statements in addition to the definition, and clearly stating that pain is always a personal experience and it's influenced by all these factors, biological, psychological, and social, and that we learn pain, and that pain and nociception are different, that a person's report of pain should always be respected 100% of the time. It's real. And although pain can serve an adaptive role, it may have an adverse effect on function and social and psychological well-being, and we'll talk about that. And a verbal description of pain is only one of the ways that we express pain. If we can't communicate it, it doesn't mean someone's not in pain. Let's look at some statistics of the life impacts of chronic pain or persistent pain on the people experiencing it. These are statistics on how it affects our life. It's not just the pain itself, right? That we feel the pain, it's that it has a domino effect on our entire life, our lifestyle, independence, our ability to engage in these activities, exercise, social activities, driving, walking, having sexual relations. All these can be impacted. And then the social aspects. 1 in 4 people have strained or broken relationships with family or friends. That's a pretty high statistic. It puts a lot of stress, a lot of strain on our social relationships. And then what about the life impacts of chronic pain? These are the feelings we have from experiencing those losses of being able to engage in those activities of life that are meaningful to us. Loss of independence, threat to integrity. We have decreased positive expectations, maybe even loss of the meaning of our life, or increased despair, decreased self-worth. We can feel just confused about life. Everything feels uncertain. And this can be called narrative wreckage. That comes from narrative medicine term. Kind of means people say my life's a mess sort of thing. We were going along in life. We kind of were sailing along, and then, man, everything just kind of changed and is impacted by the experience of pain. So this is a little graphic I made, and it's based on Joletta Belton. If you are familiar with Joletta Belton, who shares a lot about her pain experience and also teaches, she shares this kind of diagram about the pain experience, that when we're experiencing persistent pain, the impacts on our life, the pain becomes so much bigger than our life. And I think you just saw that in those statistics. This is what can happen to our life experience. It becomes all about the pain. So the World Health Organization has said, how do we help people with improve their experience of pain? And the solution they've identified is to focus on functional independence rather than treating structural or functional impairment. This means treating the symptoms of the pain alone really isn't as effective as working with a person to be able to do the things they want to do. So just some more background for you on that. So back to the occupational therapy perspective. We believe humans are primarily doing beings, feeling beings, and we think, rather than thinking beings who feel and do. So we're going to take the approach and the perspective when we work with a person to really dig into, what is this experience like for you? What is life like for you? What is engaging activity like for you? How do you feel about it in your body, and also physically, in emotionally? And then how does that affect your thinking? And go kind of back around. So using this perspective, back to this model again, the act, feel, think. This is what we're going to explore as we continue on here. So I want to bring up another little piece of evidence to you too, and is that there's evidence that doing in occupations, it has the ability to alter the perception of pain. So we know, like, we can alter the perception of pain with some of the modalities or things we might use to try and treat symptoms, but were we really aware that engaging in an activity can alter that perception of pain as well, and is actually even more powerful because we are then tapping into our own what's called endogenous opioid system, the biology, the physiology of our own body, and what the potential our bodies have to mediate that pain experience. So this is a doing with instead of a doing to perspective and approach. We feel better when we do activities that are meaningful to us. And I want to say this is why occupational therapy came into being over 100 years ago. Dr. William Dunton, who's considered the father of occupational therapy, realized that these patients in the psychiatric hospital that he was working in were not getting better with traditional psychotherapy methods. And so he did a really radical thing at the time, and he built a wood shop at the hospital for those patients to then become involved in an activity and a meaningful activity to them and learn. And it made all the difference. And that's really how occupational therapy was born. So let me give you a little quote from Joletta here, going along with that, how occupation changes our experience. She says, pain is experienced by the human, not by a body part, not even by the brain. And that complex human lives in a complex world. So that doesn't mean you have to know how to fix their pain. It means you can help them to get back to living their lives, knowing we can change our experience and that our lives can get better. And that can happen even if the pain doesn't change. Life can be better if we get back to living our lives. So the model, the idea is to get more life, less pain. That's the occupational model for working with people with pain and for helping people recover and have a better life from pain. That if we focus on life, if we focus on engagement in life, this really is what happens. And Joletta shares that in her personal experience. That's her story. She made life bigger, and when she made life bigger, pain got smaller. And that's our goal. So let's talk about, if pain is an experience, how can we better understand what that experience is like for people? So now I'm going to kind of take you into some different methodology and ways we can do that. But at first, I'm going to give you just a little challenging test. So I want you to look at this picture and try to determine what you think it's a picture of. It is an actual picture of something. I know there's a few people on here who have seen this before, so they will have already had an experience with this, but this should be a new experience for most of you or many of you. And just think about, what do you see here? What is that? Write it down, put it in the comments if you want. What do you think that is? I'll just give you a couple seconds. Try to analyze that. And so here we are. Here's the slide I showed you. And now let me show you what it really is. And I wonder how many people got it right. People get competitive about this when I do this live too, but it's really interesting to hear different people's interpretations of that first picture and what they see in it, because the idea of this is you're going to see in that picture, based on your experiences, based on your knowledge and your experiences, you're going to bring that to your interpretation of that picture. This is exactly what we do in everyday life. Each of us brings our own experience, our own background to interpreting the experiences of our life. But once you see it, interestingly enough, if I go back here, you can never unsee this anymore. If I've shown you the real picture, you've had an aha experience, you can't unsee it when you look back again. We call this experiential blindness before you saw the actual image. It means you didn't have enough experience. If you didn't get the B right, I guess, if you say, you don't have enough experience with it to really know and make sense of it. But once you've seen it, once you've had an experience, you have some awareness, you have some knowledge that you can then bring to the experience and experiences in the future. You're no longer blind to that experience. It's the shift from unknown to known. This is what we learn when we learn experientially. It helps us make that shift from the unknown to the known. And once we've made that shift, we can't unsee what we've learned. So understanding occurs through gaining this type of experiential knowledge. This is the aha moments in the act, feel, think, right? You're doing an experience, you feel, you experience, and then you do a cognitive reflection and process into it, and you have those aha moments. So to give you a little more background for those of you like evidence about why we should be doing more experiential types of learning, here's some statistics for you. Here's the sad thing. Most people only retain 25% of what they hear. And boy, do we talk a lot as health professionals. I know that myself. We talk a lot and try to teach and share through verbal, but people aren't getting. They're getting maybe 25% if we're lucky. 40 to 80% of medical information is forgotten immediately, and 50% is retained incorrectly. So people aren't remembering things, and we're just not good at it. And sometimes mix it up, especially if it's complex information. Teach-back methods are really effective, but not utilized a lot by clinicians. So if you teach something and you have them teach you back, it's much more effective learning because, again, it's experiential. The person is actually doing it and engaging and experiencing themselves. 50% of Americans have difficulty understanding and acting on health information. We know the application is a really difficult part for people. If we just are giving information, it's really difficult for people to apply it to their real lives. But hey, guess what? People who are active participants are more satisfied, and that makes sense. 95 to 99% of chronic care condition is guided by the individual with a condition, not by those of us who are health professionals. I tell my clients, you do 95%, I'm 5% just there to help you do that 95% because you're out there living life, and I'm here to support that. So here's what people will say to us too. What am I supposed to do? How do we do this? What am I supposed to do? I call it learn through living it, this doing approach, learn through living it. We also have to understand that teaching experientially and through activities is much more effective for another reason too, and that is the statistic you see on the right. 49% in the world, 52% in the US of people have basic or below reading skills. So again, if we're trying to teach through just giving information that's printed or even verbally, as you saw in those other statistics, we're really not as effective. We're making it much more difficult for people to learn and apply the types of things that we're trying to help people learn. So let's look at the big picture of understanding personal experiences. We're doing, feeling, and thinking beings, and every day we have the ability to influence that lived experience. As health professionals, we're trying to help people understand these experiences so that people can take the lead on their own self-management. And having a deeper understanding of how we're experiencing life can help us to make plan for improved life and pain experiences. We can change those lived experiences that we're engaging in every day. And so some of the questions, how do we know if people are going to get the aha moments and that experience that they can't unsee if we're just giving information, if we're not actually out there doing with and helping people reflect and back and process through we're experiencing life? how do we know that that application is happening? And I want to propose to you to realize that all biography is biology. What I mean by that is this lived experience that each person has that's living with pain, that's their biography, and we're living that in every moment of every day. But it's also all biology. So all biography is biology. And so we can affect our biology by changing our biography, changing these stories, changing these experiences. It does change our physiology, our biological processes that happen in response to those experiences. So back to reviewing again that everybody engages in doing every day. This is our common experience. All types of different activities too, some for more recreation, some are social, some are self-care, some are work, meditation, but whatever we're doing, we're engaged in doing every day. So we want to dig into the experiences and how we're experiencing not just what we do, but how we're experiencing what we do. How do we get some data of this? How do we get this doing data to help us better understand this lived experience of pain? So one of the things we have to do is dig deeper than pacing. Pacing is a good general form for us to use, general structure to kind of say, yes, we need to pace our activities through the day, how much we're doing, the types of things we're doing. But what if we took those activities and we really dug into the activities themselves and what we're experiencing during them, not just pacing them, but what are we experiencing while we're doing them, and what factors influence our experiences of doing. So what I'm going to share next is based on Karen Atler's work in the development of the occupational experience profile. And I've been a clinical advisor to Karen for about 6 years or so. It's been, well, 4 years. It's been out for a few years now in the development of this profile. And I told Karen when she first came to me that this was a piece for my work in helping people with pain that I felt was missing, because it gave me that structure and that way of really looking and digging into this doing data, if you will. What are we experiencing when we're engaged in activities? So I'm just going to give you a brief overview of it, but this is what this is based on. So in order to start collecting this doing data, if you will, I call this step one, the 3 W's. Karen calls it something different in the official profile, but this is what I call it for our purposes. First of all, what? The 3 W's. The first one is what. What are we doing? What do we call the activity? Everyone can call their activity something different. Some people call a self-care activity self-care. Some people might call it something different. Some recreation activities they might call social activities. You know, we can name what we call it, but what are we doing? What do we call it? What type of activity is it? And then where are we doing it? Context is really, really important. Where are we? What's the environment like? We can dig into that and how that can affect the way we experience what we're doing. And then the third piece is, who are we with? What's the social connection or lack of social connection? Are we alone, or are we with people or certain people? These 3 pieces of data are critical, and then we'll dig into the actual experience, but we have to collect the what, the where, and the who with of the activity. And then step 2, we're going to look at the actual experience. And here's where we get into these 4 measures of how we experience the things we're doing. The first one is pleasure. How pleasurable was this activity? Now I'm giving you a scale of 0 to 10 that we can use to rate on this. And I want you to think of 5 as just kind of being neutral, like, nah, it's okay, not super pleasurable, but not unpleasurable or displeasurable. Anything less than a 5 would be a measure of displeasure, and that'll be the same for these other factors too. And so you're going to have a time in a minute to do this actually for yourself. So to actually do a little activity of your own. So we look at what's the pleasure levels for this particular activity. The second one is how productive do we feel? What's the productive? Do we feel very productive doing this activity? Neither. Somewhere in between, again, on that scale, or do we feel unproductive? The third one is restoration. Now, what restoration means, it's a measure of energy. So do we gain energy from this activity? Do we get energy back? Is there a restoration of our energy? Is it kind of neutral at that 5 level, or is it something that is draining our energy? And so it's not restorative, below 5. And then the fourth measure is social connection. And again, rating the quality of our social connection. 5 is neutral. Above 5 would be a really positive social connecting experience. Less than 5 would be, yeah, that's a negative social connecting experience. Now, I do want you to be aware that normal life has a mixture. Not everything is all pleasurable. Not everything's all productive and positive and restoration, everything. We have a balance, right? There's some that are going to drain energy, some that are going to give back, some positive social connections, some that aren't so great. That's normal. But we can reflect back on our experiences and look at it as a whole and see if the balances are right for us as an individual. And does it line up with our values and our meaning? Are we engaging in activities that are going to be that restorative? Those ones that we talked about that can alter our pain experience, obviously are going to be the right kind of balance and having more pleasure, productivity, restoration, and social connection in our lives. So now I'm going to give you a chance for you to do this activity for yourself, because the way you're going to learn, again, is through experience. And so I want you to reflect back on yesterday's lunch. It was a Monday, so we know how Mondays can be. So I'm not sure how your lunch was and how you experienced yesterday's lunch, but I want you to look at this slide and take a few minutes to jot down, first of all, what were you doing at lunch yesterday? I mean, hopefully you're eating lunch. Where were you? I'm sure people were in all different environments. Where were you eating your lunch? Who were you with? So write down those 3 elements. Those are the 3 W's: what, where, and with. And then I want you to take those 4 scales and rate your lunch experience yesterday using that 0 to 10 scale. Again, 5 is neutral. Above 5 tends to be on the positive side. Below 5, yeah, not so fun. So was your lunch pleasurable yesterday? How would you rate that pleasure? How productive did you feel at lunch? Or did you feel very productive or unproductive? And sometimes unproductive lunches, that could be a good thing for a lunch activity. Restorative, did you get energy back from your lunch? Or were you working through lunch? Or was it stressful? And what about social connection or your lunch experience yesterday? How was that experience for you? And after you write these down for yourself, then you want to take time to reflect on it. How is that for you personally? And if you'll see over on the right side of the slide here, I've listed a few things: values, meaning, goals that you could reflect on. Does your lunch experience line up with how you really wanted to experience your lunch or would like to? How would you say, did it line up with your values? Was it meaningful to you? Did it meet any of your goals? Yes or no? What do you discover about it? How did the environment impact how you experienced it? How did the people you were with alter your experience of it? And if you could even reflect back to how you felt in your physical body while you were having lunch yesterday, how did you feel? And how could any of these factors have had an influence on how your body felt? And then think about if you're a person with pain, or if you're working with a person with pain, how doing this activity like this could give you some data that can then help reflect back on the actual physical experience of pain, and which factors were possibly influencing a more positive experience during that lunch, or maybe a not so great experience, and then what could be adjusted. And I think if you dig into this, this is a simple example, but it's an example that can be used in any activity. You can begin to find these connections that maybe you were never aware of before, that change again, that biography that can change the biology, can change the pain experience. And then how do we alter the experiences throughout our day so that we can improve that life experience? We can shrink that pain experience and increase the life experience. So I want to give you a few examples of why this is important for self-managing pain. So restoration is one that I think a lot of people struggle with, and the people I work with even struggle with that concept of restoration, restoring energy. And often we teach too, and we teach pacing, that it's the rest periods that we're supposed to build in. But so often rest is not restorative. It isn't necessarily restorative. And if we dig into these kind of experiences and that data that we just looked at, we might discover that it's not restorative. So I've had a client who used to take a rest break on the couch, which was great. It was an activity break. But when we looked at the way she experienced it, when we did those measures, her pleasure was less than 5. Her productivity was like 0. She felt super unproductive. Her restoration was like nothing. Like she got no restoration from it. And as we talked about it, realized, I asked her, why is the rest not restorative for you? And she said, well, all I do is lay there and I think about all the things I can't do and all the things I should be doing and how upset I am that I'm in pain and I have to take this rest. And I thought, wow, that I never would have known that if we hadn't dug into this. And how can we change that rest for you so it's not that experience? And she came up with some different strategies to listen to music or put on a book on tape, or something that she could refocus on that gave her a different experience, and it changed the way her body responded to it. Because when she was in all that shame about I can't do, her body's going into fight or flight shame response, and that's actually increasing her pain awareness. I've also had on that restoration, I know for myself personally, I can feel really, really tired and want to nap. But if I go play the piano, and I'm not a great pianist, but I like it, if I play the piano for half an hour, I feel like I've had a 2-hour nap. I've had another client also, same thing. She's a pianist and discovered that for herself, that she got restoration when she played the piano. What are those activities that actually give us energy back? It's not always a rest, it's a restorative activity. I've also had clients who looked at their activities and realized that it's all about being productive. Like everything was productive, no pleasure activities built in, no social connection. And so then they can change and alter their life experiences and what they're doing to build in and to be more intentional with building in those activities. So it can be a way of setting personal goals for that person. I also had a client who realized that her pain went up and was highest in all the times she was alone. She lived alone, and that's when her pain was always the highest. And so she actually got a roommate. Who would have thought of that? She got a roommate, and it helped her pain experience in her daily life because she got that insight from exploring how she was experiencing her activities of daily life. Some people find that certain people they talk to either help them or can make their pain experience worse. And then how do you alter those social connections so they're of most benefit for us? And people can explore too maybe activities they gave up that they think they can't do because they're in pain. But what we actually find is getting back into those activities helps, that those really important, meaningful activities, we can re-engage with them. They really help. I have a number of people who've said, no, I can't do that, or I can't work, or I can't do this because of my pain has to get better first. But when we switch it around and we reconnect to those really meaningful activities, and sometimes it's going back to work just very part-time, that actually really helps because the individual needs to feel productive and it's meaningful, there's pleasurable social connections, whatever it is. So reconnecting to those are really important. Also, think again about the context and the environment that we're in and how that affects us physically. The sensory processing that our bodies have to engage in every single environment we're in. If it's too loud, too bright for us, we're going to have a physiological response that can then influence again that heightened pain response. So being aware of altering the context and the environments can help, but also too little stimulation also is not the right balance. We need sometimes to add some stimulation to increase that experience. I have many of my clients who learn to put on their favorite music when they're emptying the dishwasher because it changes that experience from not so great task that they don't like to do to something that's more fun. So this is the doing data, the story data that we can mine to help us dig into what is the lived experience, and then how can we alter that experience to then help a person alter their whole life experience. The environment, the social factors, values, meaning, what happens to our pain experience when we're doing these different activities. Is rest really restorative? Is the balance healthy for that individual person? Is isolation a factor? We know that's a big factor for a lot of people who experience pain. Certain people, like I said before, and then how do our emotions, how do we feel about it? How does that impact? How do our beliefs and our fears influence our daily experiences? And I want to get back and just make sure, some people are going to say, yeah, what about graded exposure and pacing? Of course, we continue to talk about graded exposure in engaging in activities and doing things in pacing. I put this picture up because this is the metaphor and analogy I use with my clients about graded exposure and pacing. And we joke about it. It's don't burn the toast, basically. And learning how to kind of modify and make that daily activity and approaches to the activities we're doing so that we're not overdoing it and burning the toast. And sometimes we burn the toast, but it's okay. We also learn from that experience. But we can integrate this into, again, another factor of looking at the way we're experiencing the activities that we're doing in everyday life. So back to, again, the occupational perspective. We are doing beings who feel and we think. And so starting with the doing, exploring the doing, how we're feeling about it, both emotionally and physically, gives us the ability to then reflect, have aha moments that then we can reflect back on it and change again, go kind of like a circle back to the doing, feeling, thinking. So the life story, again, here we are, the impacts of chronic pain that we talked about before. These are the real life experiences that people are having. And an awareness that changing our biography, changing our stories, changing the way we experience our activities of daily life can change this narrative for us, can change our biography, changes our biology. So what is the path forward? Well, this comes from narrative medicine approach. We want to rewrite our stories, right? We want to write and be in charge of our biographies. And as healthcare professionals, we want to enable the people we work with to be writing their own stories. That's our main purpose, and our main goal is to come alongside people and help people develop the skills and awareness and experiences and knowledge and the ahas so that they're out living the 95% or more that they're in the world living their lives, that they can write their own stories. So understanding the stories, the experiences, the biographies that we're living every day is imperative. And recognizing that this recovery process, it's slow. It's not a quick fix. It takes a lot of intention. Some people call it a journey. You can call it whatever works for you, but it is a process. And we're trying to gradually restore those connections that help. We're trying to get the balance is right. And the biology, the psychology, the social, the whole life picture. But what it requires from us is a lot of imagination, creativity. We have to get quiet with ourselves in our experiences, reflecting back on what we're experiencing and what we can be empowered to do to change that experience as a person in pain. And as a health professional, how do we help a person get that insight and that awareness? How do we have empathy for ourselves, self-compassion? How do we not try to reach perfections in what we're trying to do or set unrealistic goals for ourselves, but instead live the experiences with curiosity and self-care and self-compassion and kindness for ourselves, that, hey, this is tough, but we can work through it, and we're going to learn. Just like we don't know that picture of the bee before we've seen that it's a bee, we're going to be in that uncertain time for a period of time while we're living and learning and processing and having these aha moments. So I always want to end with kind of this little picture, and then I want to share another quote with you. But this is a picture I use about jumping out of the fishbowl of looking for a physical fix towards this fishbowl where people are learning to write their own stories. They're understanding themselves, their experiences, their bodies, to have the ability to do that. But it takes courage to do that. It's a little slower, it's harder to develop these skills, but it's all about self-discovery, building that self-esteem, that belief in yourself, that you can make a difference in your own life. And in particular, by increasing your life, that can shrink the pain. The experiences you have in life have a powerful effect on your everyday pain experience. And lastly, I always, always, always want to end with a quote from a person with a lived experience of pain. So you're just not listening just to me. And Keith Meldrum, I know he's a great friend of Pain BC, and he's a great friend of mine. And I just really, really admire his work. And The Path Forward is his blog, by the way. And so this is a quote from him. Living with persistent pain is hard, really hard, but it does not have to be all consuming and the sole focus of our lives. When we start to consider what we can do, and less about what we can't do, we develop self-efficacy, and we can start to live better despite the pain. And Keith says, refocusing away from what we can't do was one of the most important changes I needed to make. When we refocus our energy away from fighting into those things that we can do, to those things that offer us contentment and joy, we begin to live better. I can't imagine saying it any better than Keith does. That when we refocus towards the things that we can do, the things that are meaningful, bring us joy, we begin to live better, and that changes the experience of living with pain, the human experience. So with that, I'm going to switch to questions. And I think Jen is going to pop back in here and kind of help us finish up. I saw lots of comments. I see there's like 40 comments, so I have no idea what people are saying, but
yeah, there's lots of activity in the chat. So yeah, which is great to see. I just will ask people to, if you do have a question for Linda, just put it in the Q&A, which should be depending on where your controls are, possibly in the top left-hand corner of your screen, or possibly in the bottom of your screen. So I'm not going to be unmuting people and letting them speak. I know a couple people had their hands up, but things usually get a little kind of crazy if we do that. So
I'm gonna stop share so you can just see me.
Yeah. So if you could just put your question in the Q&A or even in the chat, if that's easier, that would be awesome. So we do have a number of questions, Linda, already.
Okay,
so
I'm ready.
Let's go. Okay, so first question is, how do you delineate how occupational therapy is different than physical therapy when treating clients with chronic pain? So what makes us special in this area? So this is written by a fellow OT.
Oh,
yeah.
Fellow OT. Okay, well, I was hoping that the whole presentation would kind of give that perspective that we're really globally looking at the lived experience of people as a start for our perspective of working with people in pain. So obviously the whole biopsychosocial, all those aspects we're going to address with a person, but we're probably going to start out, hopefully, of talking about what's meaningful to you in life. What are the activities that you need or want to be engaged in? How are we going to help you get back to that? And we'll talk about the physical pieces as well and how you feel about it. But that's our primary focus. And I work in community-based, so I'm in real life. So our OTs tend to work more out in community and in workplaces and homes than in clinic settings. So our background is, we were founded from mental health, which you heard me talk about William Dunton. So we have a strong mental health background and experience. So we kind of, I guess I call us integrators. You know, we work with other disciplines that have their more specific expertise, but we're kind of the integrators of all of that to help a person apply it and make it real in their life. And I hope I answered that well.
All right, thank you. Okay, here is some interesting questions. Okay, so in your experience, do you think there is a type of person or personality who responds better to an occupational model rather than a cognitive model?
Okay, I think I said briefly, like, we don't throw out the cognitive model. People have different learning styles too, for sure. And so if you have the ability to kind of assess their learning styles and how they like to learn best, that can help inform you if you're trying to give a lot of educational stuff. So I have, you know, there's some people who they want the handouts and all that. That's still good, but I wouldn't say that there's anybody who doesn't need to do this work in this occupational model, that we all can benefit from reflecting on how we're experiencing our daily lives, whether we're in pain or not, just for our general health. I do this all the time. When COVID hit, I went back to this model and looked at my entire life. I made a big whiteboard out in front of me. What am I going to do that's going to be pleasurable, productive, restorative, and have social connections now that I'm not out in the world? And I did this for my own life because I knew the balance that I needed to have, and that it was that COVID threw me into, you know, a total different world. And so whatever it is, we can all benefit from exploring how we're experiencing our activities and how that balances for us.
Great, thank you. Yeah, I mean, I can certainly see the relevance to my own life when you started talking about that piece. Okay, so we've got a question here from an OT in a hospital, and they say they don't have a lot of time to work through this stuff with patients. So do you have any advice?
Yeah, that's a great question. I think you can still do it. And I think we should adapt it in a smaller way. I mean, if you're in a hospital setting, you already know the environment you're in, but you can ask questions. So how did you experience that activity we did today? If you had to, talk about, was it restorative? Let's say you're trying to do restorative or social connecting. You can ask questions around how they're experiencing. How do they feel in their body? Were they feeling really tense? Do they feel more confident now after doing the experience? Have they had an aha moment? Have they learned something? What do they need to support themselves in engaging in therapy with you? What would be helpful? Like, is the environment good? Or do you prefer doing it in a quiet room? Or would it be better if, are they okay out, like where there's more people or in a therapy gym or whatever? So think about it for yourself too, and then think about how you can create some questions that you can just ask while you're doing activities or after you're doing activities.
Wonderful. Okay, thank you. Okay. Oh, here's a good one. Can you expand on how to gather the data? I guess this is the data from people. So do you ask the client to rate all activities over a couple of days or a week? Do they rate pain as well as the 4 factors with each activity? Like how would you approach that?
Yes. So I gave you like the very small appetizer of the occupational experience profile. So that is an entire profile that's available. If you're interested, you can look up the Colorado State University Occupational Experience Profile. You will find it. So there's an entire assessment that you can do with clients. And there's a training module for that and how to use it. So if the reason I gave you the appetizer is because we can apply that little appetizer anytime too. If you want to do a really full deep assessment, then I would recommend getting the profile. With that, we usually record 3 days. A person does a time use diary. There's also an app. There's an app that can be used for that. And they rate everything, and then they reflect, and then we sit down and we reflect again. And it's also a great way to look at goals, changing goals for people to meet what their needs are. But realize that you can do this little version as well. But there is obviously the much more expanded version that's going to help you mine a whole lot more data. And when I do this, we add pain to it. To look at their pain levels. We look at values. We dig into all kinds of different stuff when you have this whole big amount of data in front of you.
And sorry, Linda, can you say the name of that tool again? It's
the Occupational Experience Profile.
Okay, great.
Occupational Experience Profile.
Because one of the other questions is where can people find further resources? So that would be really the go-to.
Yes. Yes.
Yeah. Okay, great.
And you can look up Karen Atler's work too. She has a number of published journal articles. So Karen Atler.
Okay, brilliant. And I think, there was a question here. Do you offer any training for OTs?
Well, I do a lot of these webinars. I do have a Pain OT Facebook group. So that's a group where we're doing, tomorrow night we do free happy hour educational things on different topics. There we support each other in learning, and there's a whole bunch of people in there who are amazing, who are specialists. So I would recommend starting there. Pain OT, I do a number of different webinars And watch next year, there might be some more. I've taught at AOTA courses, and so there's more coming.
So Linda, can you just say the name of the Facebook group for folks in case they want to join?
Yep, Pain OT.
Okay, so just search
Pain
on that.
OT. And
yeah,
you can find me, I have a public profile, Linda Crawford OT is my Facebook profile. So if you find me, you'll probably find Pain OT, or you can message me and I'll connect you.
Awesome. Okay, so here's one. Probably this is we do have quite a lot of questions, but we are just about at 1 o'clock. So this will be the last one. So what are conversations like when you've been able to convince someone to try occupations that they're feeling sure that their pain will prevent or limit them from doing? Are they more about telling clients that about other people's experiences, educating about the endogenous opioids and how participation can change their pain? He says, I'm sure it depends, but just wondering if you've had more success with some methods than others. So it sounds like this is a question around encouraging people to try different approaches.
Okay.
Yeah.
So, well, particularly, people, we tend to be very fearful sometimes, right? When we're experiencing pain, we don't know how we're going to experience something different. We don't know what it's going to be. There's a lot of uncertainty. And so it's weird that I have this advantage, but one of my advantages is that I have a lived experience of pain. So being able to share that helps in my case. So when you say sharing other people's experience, yes, kind of, but it's my own personal experience that yes, this is tough. First of all, I validate, always validating whatever the person's feeling, and that I'm never gonna ask or push a person to do something. It's more about, can we explore this together and experiment? Bronnie Lennox Thompson likes to talk about it. We're about experimenting. Can we experiment and explore some things and discover with the person how this is going to work for you, and that it's a mutual relationship, a feedback and a working together kind of thing. So I'm not sure I can expand on all the ways I do that with people in this little few seconds of time, but that's kind of the approach there.
This sounds like a good thing to talk about in the Pain OT Facebook group.
Yeah.
Yeah. So I'm sorry that we didn't get to everyone's questions, but I think some of those the groups that Linda provided would be a good place to continue those conversations. And I just want to thank everyone for coming today and participating. And Linda, lots of people have commented they really enjoyed the presentation, and just want to say thank you on behalf of me and on behalf of Pain BC for sharing this information with us. It was really wonderful, and so nice to see you again.
Thank you. It was great to be here. Thanks, Jen. Thank everyone for coming.
Thanks, everyone. I hope you have a great week and hope to see you next month. Bye.